Okay, we'll go ahead and get started on the axial skeletal muscles. Today, again, these are the muscles that involve the head and the neck, the muscles of the vertebral column, the oblique and rectus muscles, and the muscles of the pelvic floor. If you've had a chance to look at the lab assignment already, what I've done is tried to group all of the muscles together for you. That's a great way to study for the exam. I'll go over that PowerPoint presentation before the end of class today, but make sure, you have to go over those of you who are in the lab are required to. You'll have to go over that PowerPoint presentation anyway. But all of the muscles have been grouped for you. What I've also done is limited the number of muscles that you will be responsible for. So make absolutely sure that you go over that. Now, on the exam, the other thing that you should kind of focus on when you're studying for this, look at the names of the muscle. Sternohyoid muscle, for example. Sternum, hyoid bone, gives you some idea. The sternohyoid muscle will not be related to any abdominal structure. So if I would ask you a question about a muscle that compresses an abdominal organ, it's not going to be the sternohyoid bone. Why? Because you know the sternum and you know where the hyoid bone is. So look at the name. If it has the term glossus in it, as we talked about suffixes last week, glossus is going to have nothing to do with movement of the lower extremity. So you can quickly identify which muscle fits into a group and which muscle does not. And the whole exam, I won't say the whole exam, but a lot of questions on the exam are made up simply from those relationships, being able to identify where a particular muscle is. And if you study the groupings of muscles on the lab portion, hamstring muscles, muscles of mastication involved in eating, muscles of facial expression, those groupings of muscles should be related. You should be familiar with that, and you should easily be able to pick out the muscle that doesn't fit into that group. But we'll start with the muscles of the head and neck. Some of the key muscles here that you're going to be responsible for identifying are muscles like the orbicularis muscle. As you can see, there's an orbicularis muscle, a circular muscle around the eye. There's also an orbicularis muscle that's around the mouth. One, orbicularis oculi, the other, orbicularis oris. There are also other muscle groupings that we'll talk about across the time period today. Other muscles involved in facial expression, starting with the muscles on the forehead. If you remember earlier, we talked about a large tendinous sheet that allows muscles to attach to bones. One of the large muscle tendons is referred to as an aponeurosis. As you can see, the frontal or the epicranial aponeurosis, which attaches the frontal belly of the occipitofrontalis muscle to the frontal bone. Other muscles here in the face that are important, nasalis bone, procerus bone, these are muscles that are associated with the nose. There are other muscles of facial expression, the zygomaticus muscles, muscles of mastication, which include the buccinator muscle and the masseter muscle, the pressa anguli muscle. And then you can see some of the big muscle structures that lie anteriorly. The platysmus muscle is a large, flat, thin muscle that lies in the anterior surface of the neck. And then under that muscle, you'll have to remove the platysmus muscle to be able to see the sternocleidomastoid muscle. The sternocleidomastoid muscle is important to bring up. Not only does it involve the anterior flexion of the neck and rotation of the neck, but it's also an important landmark clinically because major blood vessels will lie along the course of this muscle. Medial to this will be the carotid artery. You can feel the pulsation of the carotid artery just by putting your finger basically on the Adam's apple and sliding laterally to the point where your hand is literally resting on the most medial belly of the sternocleidomastoid muscle, and you can feel the pulsation of the carotid artery. It's also an important landmark clinically because the internal jugular vein will lie next to the artery. And so for clinicians who are inserting central intravenous catheters, typically you put your finger on the pulsation of the carotid artery, again, which is just along the medial belly of the sternocleidomastoid muscle, and then just lateral to that would be the location of the vein. Now remember, veins don't have pulsation, so you have to use the artery and the sternocleidomastoid muscle to be able to know where the internal jugular vein is located at, and you can start an intravenous catheter there. So it's an important landmark to be used in the body, especially anterior neck, when you talk about establishing venous access. The other muscles that are important for you to know and recognize are the extrinsic eye muscles. These are the muscles that are involved and I remember doing this slide because I didn't change the label. This is the wrong label for the slide. It says intrinsic eye muscles, but actually this talks about muscles of the face. So this is where we left off. But anyway, so the labeling is wrong here. This really talks about the facial muscles, and the largest group of the facial muscles are associated with the mouth. I've already said the orbicularis oris muscle constricts the opening of the mouth, muscles that move the lips and the corners of the mouth. The buccinator muscle also function related to eating, or one of the major muscles in the muscles of mastication. And then the importance of the muscle, especially the buccinator muscle, when we talk about those individuals who play musical instruments, trumpet players, utilize this muscle. If you ever watch a old video of Louis Armstrong when he's playing the trumpet, and watch how pronounced his buccinator muscles are and his masseter muscles when he's blowing the trumpet. I mean, has anybody ever seen that? No? No? Oh, okay, and sorry. But anyway, if you do get a chance to watch it, very pronounced muscles. So, in infants, the buccinator muscle provides the suction or suckling of the breast. And then we get to the extrinsic eye muscles. 6 of them, all of them are related to extraocular muscles or oculomotor muscles originating on the surface of the orbit. They position the eye, they control the movement of the eye. It includes inferior rectus, medial rectus, superior rectus, lateral rectus. Inferior oblique muscles, the oblique muscles, inferior oblique and superior oblique, are the muscles that help control the 360 degree in the anterior plane. The 360 degree movement of the eye is related to the inferior oblique muscles. And I talked about these again last week. Extrinsic eye muscles are innervated by the 3rd oculomotor nerve, you should be familiar with that, and the 4th trochlear nerve, and the 6th abducens, away from, abducens nerve, cranial nerve. So, and this is an illustration out of your textbook that demonstrates these muscles: lateral rectus muscle, the oblique muscles, the inferior oblique muscles, the inferior rectus muscles. There's also a superior rectus muscle, or a better picture here, superior rectus muscle. Again, superior rectus muscle, when it contracts, brings the eye up. Inferior rectus muscle, when it contracts, brings the eye down. The oblique muscle, as you can see, when it contracts, it's going to rotate the eye. Lateral rectus and medial rectus, again, there's a relationship between the eyes, a mechanism referred to as tracking. When you have a neurology or the nervous system next semester, then we talk about tracking a lot more, and how the coordination between the nerves, the oculomotor nerves, the abducens nerves, trochlear nerves, how all those in coordination help you to track. When one muscle contracts in one eye, the other muscle has to relax to allow both eyes to track together. Eye movement typically is matched on both sides. The muscles of mastication, these are the muscles that move the mandible and the temporomandibular joint. These are the large masseter muscles, which are basically the strongest muscles of the jaw. The temporalis muscle, which again lies over the temporal bone, which you're familiar with. The mechanism of gritting our teeth, resting your hands on the side of the face below and above the zygomatic arch, will allow you to feel this muscle action. There are also pterygoid muscles, grouping of muscles that's used in various combinations to help elevate, depress. The movement is called basically lateral excursion, when you're jutting your jaw or moving your lower jaw from right to left. Movements are important in making the teeth work efficiently when grinding and chewing food. Muscles of mastication are innervated by the 5th cranial nerve, also referred to as the trigeminal nerve. You should be familiar with that as well. Illustration from your book again, demonstrating the temporalis muscle, the masseter muscle. Again, if you get to watch a Louis Armstrong clip, you'll be able to appreciate those muscles. And then the grouping of muscles here on the lab exam, I asked you to identify these muscles. I just need pterygoid muscle. You don't have to differentiate between lateral and medial pterygoid muscle. I just want you to appreciate the grouping. Muscles of the tongue. Again, the term glossus, which I already referred to earlier. Muscles of the tongue. Name ends in the word glossus. Glossus muscles derived from the Greek word meaning tongue. Also called structures referred to as palato, stylo, genio, and hyo. All are basically self-explanatory. You're already familiar with those bones. Stylo process comes off the mastoid process on the temporal bone. You should be familiar with that structure. Stylo, hyoid tells you the origin and insertion of that muscle. And again, hyoid bone relates to the small bone that lies in the anterior aspect of the neck. If you see hyoid associated with the muscle, then you know basically the general area where that muscle must be located at. Palatoglossal muscles originate at the palate. Styloglossus originates at the styloid process on the temporal bone, and the genioglossus muscle at the chin, the hyoglossus muscle, and the hyoid bone. These are muscles, again, that we see along the pharynx and the larynx area of the muscles. These muscles are important in elevating up. Again, next semester when we talk about the digestive system, you'll see the importance of muscles whose role are to lift and close the glottis, so when we swallow food, food goes in the right direction. Two openings in the back of our throat. One is for air, one is for food. It's not good to get those mixed up. If you get food down where air is supposed to go, you aspirate, you choke, you cough. You may even get pneumonia. If you get air in your stomach, you get bloated, you get distended, you may have reflux. So it's important that these muscles work to help open specific the specific openings in the back of our throat to allow food and air to pass in the right direction. Again, you'll see on the lab exam when I ask you to identify these muscles, I'm looking for pharyngeal constrictors. Now, it's broken into superior, middle, and inferior, and I guess technically speaking I could easily ask you that because it's pretty well defined. However, I'm basically asking for the pharyngeal constrictors, and I just need that grouping of muscle. I know some of you will be specific. Some people write like little paragraphs under the answers, and I always like that. But it's nice, but it's really not necessary. But basically all I need is pharyngeal constrictors. Again, the importance of these muscles of the pharynx responsible for initiating the swallowing reflex. Pharyngeal constrictors, superior, middle, and inferior, move materials into the esophagus. The laryngeal elevators are muscles that elevate the larynx. The two palatine muscles, basically tensor veli palatini and levator veli palatini, these muscles elevate the soft palate and the adjacent portions of the pharyngeal wall. They also pull open the entrance of the auditory tube, and as we discussed last week, when you fly on an airplane, if you want to pop your ears, you can swallow real hard, which will slightly change the pressure inside the internal auditory meatus. Or you can yawn. Again, that reflex helps to change the pressure in the tubes and can help to pop your ear, because there is communication with the posterior pharynx in the ears. Muscles of the neck, again, we've already kind of referred to these earlier. Sternocleidomastoid muscle, you know you're going to have to identify that on your lab exam, sternocleidomastoid muscle. There are also other muscles here that are part of the lab, the written exam, the lecture exam, are just related to this relationship with the hyoid bone and being able to recognize that bones with the prefixes and suffixes related either to glossus, prefixes related to hyoid bone, where these groupings of muscles are. Now, the majority of these muscles are responsible for movements related to the anterior structures of the neck. To a degree, some are involved in flexion, anterior flexion of the neck, some with rotation of the neck. But all of these bones, and you can see the importance of the small little hyoid bone, if you remember that from studying the skeletal system. You can see the importance of this little bone, a key point of muscle attachment for many of these bones. Again, geniohyoid bone, stylohyoid bone, thyrohyoid muscle. I said bone, I mean muscle. Sternocleidomastoid muscle. Now remember, sternocleidomastoid muscle doesn't actually attach to the hyoid bone, but you should appreciate, again, sternocleido, sterno meaning it attaches both to the sternum and to the clavicle. Sternocleido is where the name derived from. These are the muscles of the neck. Again, digastric muscles, small muscles that also lie here, provide muscular floor of the mouth, aided by deeper muscle structures, the geniohyoid muscle, and extend again between the hyoid bone and, in this particular case, the chin. The stylohyoid muscle forms muscular connections between hyoid bone and the styloid process of the skull. Sternocleidomastoid muscle I've already talked about on multiple occasions here, so I'll move on now to the muscles of the vertebral column. The muscles of the vertebral column are covered by more superficial back muscles, such as the trapezius muscle, which is a large triangular muscle on the back, and then the latissimus dorsi muscle, which starts in the lower thoracic and lumbar region, These are muscles that you can see. I have some illustrations coming up as well, but have a reference there in your textbook. There are also muscles that are involved in flexion, rotation of the lower back as well, erector spinae muscle, the spinal extensor muscles. There are superficial and deeper layers of muscular structures here as these muscle layers deepen. Again, if you remember last week, I showed you just a general picture of the anterior surface of muscles, or the most superficial layers of muscles. And then as we peel off those layers of muscles, there are even more muscles as we get more internal. This is just an illustration, a cross-sectional picture that will demonstrate to you the various layers of muscles. Again, as we look at just a illustration of muscles, the external muscles, as we peel away the integumentary system, this would be the most superficial layer of muscles that we see. But as you can tell by the illustrations, the deeper we go in, there are various levels of muscle planes that are involved in the system. Now, these are some of the muscles, again, that are shown in your laboratory exam that are involved with the movement of the back. Some muscles are involved in both anterior flexion, which are primarily anterior flexion, means they have to be located on the anterior surface of the body. If they're involved in extension of the back, then typically they're located in the posterior surface of the back. Many of these muscles will serve a dual role of either flexion, extension, but will also involve rotation as well, depending on where they're located at. Muscles on the right side typically will rotate the spine in that direction. Those on the left will typically rotate the spine, not only cause extension, but will also cause rotation of the spine as well. These muscles that you will have to be able to identify on the lab portion would include the erector spinae muscles. As you can see, a large grouping of muscles that attach not only on the sacrum but also the lower lumbar area, have insertion points along the upper thoracic vertebral column and also on the ribs as well. The quadratus lumborum muscles, and again, I've grouped all these muscles and we'll go over them in the presentation for the lab as well. Muscles that also are involved, and remember the cervical spine is a portion of the vertebral column, and so those muscles as well that are involved in flexion and extension movement. We talked about anterior flexion already with the sternocleidomastoid muscle. Posteriorly, we'll also see other groupings of muscles. The scalene muscles are important not only in movement of the cervical spine, but also in movement of the ribs as well. You will have to identify these groupings of muscles, the scalene muscles, on your lab exam, but they're also considered to be accessory muscles of respiration. Why? Because they can elevate the ribs. If you elevate the ribs, you increase the volume in the thoracic cavity, and so they're important muscles. Now, they're not as the diaphragm, which works by the autonomic nervous system. We don't have to think about the diaphragm moving, though we can voluntarily take a deep breath. But when we do that, we use many of the accessory muscles. Patients that have diseases such as chronic obstructive pulmonary disease that have to think about breathing, they consciously have to make an effort to take a deep breath, will use their accessory muscles. A child that has asthma, or even an adult that has asthma, or a person that's in severe respiratory distress, and you may have seen a person actually concentrating to breathe and they use the accessory muscles. When you use these muscles, taking that deep breath, you're actually contracting the scalene muscles, lifting the rib cage up, forcefully blowing air out. Other groupings of muscles that you'll have to be able to identify, and these are involved in movement of the spine. And I believe I asked 3 of these, either on the exam or the lab portion. I can't remember right now, but we'll go over the exam. But the interspinalis muscles. How can you identify this? You remember the spinous processes? Spinous processes on the vertebrae. These muscles lie between the spinous processes. Interspinalis muscle. Muscles that help rotate the spine. Look at the angle. Look how it's sitting medially on the vertebral, on the vertebrae, and then extending to the transverse process. When that muscle contracts, it's going to turn the back. And so these are referred to as rotator muscles. The other group of muscles that you'll have to recognize and be able to identify are the intertransversary muscles. Again, their attachments, origin, and insertions are between the transverse processes of the back. So those are 3 muscles there that you'll have to be able to identify. Scalene we already talked about. The erector spinae muscle we already talked about. The quadratus lumborum muscle we already talked about. So those are 6 muscles there that you should be able to identify for the purposes of the lab exam. Now, vertebral muscles, again, deep to the spinalis muscles, are smaller muscles that interconnect and stabilize the vertebrae. Semi-spinalis muscles, the multifidus muscles, interspinalis, intertransversari, and the rotators muscles. I didn't ask you about the multifidus muscle. The vertebral muscles, various combination, produce slight extension, rotation of the vertebral column, as I already said, importing and making delicate adjustments in the position of individuals in a stabilizing spine. I'll go back just for a second because I want to point out, now, when we look at the vertebral column, remember, we talked about the disc between the vertebral column and what happens if a disc gets out of place. What happens if a small muscle gets torn in the back as well? This is why back pain is so difficult to diagnose. There is such an interrelationship here between the bones and the muscles, and then remember, there are nerves that will come off each of these vertebrae at each level along the spinal cord, at each level along the vertebral column. Nerves will come off as well. Very delicate process. All these building blocks are sitting on top of each other, must be in perfect alignment. There are curves along the cervical portion, the thoracic portion, and the lumbar portion of the spine. So not only is there a curving mechanism of the spine, but then we have all these muscles that have to be set in perfect order, and then we have the vertebral column along with the vertebrae, and then the nerves that come off of it as well. So individuals can tear a very small muscle. Imagine if you damage the interspinalis muscles at a particular level. How do you identify that? Well, an MRI helps, but remember, MRI only takes slices, and so you got to get the slice right on the spot where the injury is. 1 millimeter over in the other direction, you miss the problem. And so many people suffer from back pain, and it's very difficult to be able to identify the area. That's why patients who suffer from back pain have multiple MRIs, they have multiple CAT scans, because people continue to have back complaints, but the first, second, third, fourth radiographic study that's done to evaluate it may not show the problem. In plain x-rays will not help to identify muscle problems or nerve problems. That's why you need the MRI. Very expensive studies, limitations as far as insurance is whether or not they'll pay for multiple studies. But the reason why you get all these studies done is because there's such an intricate network of functioning structures there. And so it's sometimes difficult to identify specifically where the problem is. Now, groupings of muscles, again, flexors of the vertebral column. Few spinal flexors are associated with the anterior surface of the vertebral column. In the neck, the longest capitis muscles, longest colli muscles. In the lumbar region, the large quadratus lumborum muscle. I believe I asked you to identify that on the lab. Muscles that flex the vertebral column and depress the ribs. There are oblique and rectus muscles. These muscles lie within the body wall between the spinous processes and the vertebrae in the ventral midline. The oblique muscles compress underlying structures, also rotate the vertebral column, depending on whether or which side of the body that you're on. The rectus muscles are important flexors of the vertebral column. Remember, when we talk flex, we talk about anterior positioning of the body, so rectus muscles are important in causing flexion, anterior flexion. And sometimes I try to differentiate that because some of the structures, depending on extending the arms or pulling the arms back, flexing the arms is an anterior motion. Same thing with the spine. Flexing the spine is an anterior motion. Extending the spine is leaning back. The oblique groups of muscles, scalene muscles of the neck, the intercostal and transverse muscles of the thorax, scalene muscles, again in groupings of anterior, middle, and posterior. I didn't ask you that on the lab portion, just asked you to identify the grouping of muscles. They elevate the first two ribs and assist in flexion of the neck. In the thorax, the oblique muscles extend between the ribs. External intercostal muscles covering the internal intercostal muscles. Both group of intercostal muscles aid in respiration. I think we talked about the intercostal muscles a little bit when we talked about the ribs, but basically they're very important muscles along with the diaphragm. The internal, external intercostal muscles are essentially important in respiration. Some basic patterns of musculature that extend unbroken across the abdominal pelvic surface. Muscles are called the external oblique and internal oblique muscles, and the transversus abdominis muscles and the rectus abdominis muscles. The rectus abdominis muscles insert at the xiphoid process, so you can see how it can become an anterior flexor if it's inserting the xiphoid process, the inferior portion of the sternum. The muscles longitudinally are divided by a long white tendinous collagenous fiber partition referred to as the linea alba. The linea alba. You probably should know linea alba. I can't remember if it's on the lab or on the written test. But linea alba, you should be able to recognize where that structure is. The rectus abdominis muscle is separated into two segments by this collagenous band. I thought I had an illustration on that, but I guess I don't. I'm sorry. But the linea albus and then the rectus muscle lies on each side of it. The linea albus is what divides that. If the surgeon is going to make an incision either to the right or to the left of the midline, he's got to make the incision through that rectus abdominis muscle if he's either left or right of the linea alba. Bodybuilders for the rectus abdominis muscle. Rectus abdominis muscle is where the term six packs comes from. The diaphragm, important muscle of respiration, involved or responsible for 80% of respiration. Diaphragm refers to a large flat muscular sheet, forms a wall or a partition, separates the thoracic cavity from the abdominal cavity. The lungs literally sit on top of the diaphragm. Specifies a muscle partition that separates the two cavities. The diaphragm is a major muscle of respiration. Then there are muscles of the pelvic floor that extend from the sacrum, the coccyx, the ischium, and the pubis. These muscles will have three functions. Basically, they support the organs of the pelvic cavity, flex the sacrum and the coccyx bones. They control movement of material through the urethra and the anus, either through sphincter control of those muscles. Female anatomy, as you can see, large, flat muscle structure here, almost like an apron or a hammock that supports the weight of the pelvic organs. I think I did ask you to identify on the lab the urogenital diaphragm. As you can see, there are components of the urogenital diaphragm which would include the external urethral sphincter. This is the muscle that's responsible for relaxing and constricting to control the flow of urine. Also, circular muscle walls around the vagina. There are also transverse muscle structures, again providing a supporting network of the pelvic organ. Again, you can see circular muscles forming sphincter muscles that control the movement of stool in and out of the GI tract. External anal sphincter muscles, which typically means there's an internal anal sphincter muscle as well. And then the gluteus maximus muscle. I know I asked you to identify that on the exam. Again, the gluteus maximus muscle is important because it's one of the major muscles that we give intramuscular injections in. So you should be able to identify the urogenital diaphragm. Again, I don't believe I asked you, I'm sure I didn't ask you to tell me the two muscles that are involved in this group, but you should recognize this. And you should also be able to recognize the gluteus maximus muscle. Sphincter muscles too, if I asked you to identify, I don't think I did though, if I asked you to identify this sphincter muscle or the anal sphincter muscle or the urethral sphincter muscle, again circular muscles there. And then in the male anatomy, as you can see, some of the muscles are similar, some are different. The gluteus maximus muscles obviously still the same. There still is a urethral sphincter muscle. As you can see, it lies a little more proximal here. And then there's also the anal or external anal sphincter muscle. And again, there will be an internal anal sphincter muscle, but for the purposes of this course, you don't have to identify that. Muscles also help define boundaries of the peritoneum. Muscular sheath that forms the pelvic floor establishes the inferior margin of the pelvis. If you draw a line between the tuberosities, the ischial tuberosities, you'll see it divides the pelvis into triangles, an anterior urogenital triangle, and then a posterior anal triangle. I said that right. The superficial muscles of the urogenital triangle are the muscles of the external genitalia. They cover the deeper muscle surfaces Again, if there's an external muscle structure, you know internally there are muscle sheets as well. Covers deep muscles and strengthens the floor of the pelvic floor and encircles the urethra. These muscles constitute the urogenital diaphragm, which I showed you already. Deep muscular layer that extends between the pelvic floor. I'm going to go back to these muscles just real quickly again and make one clinical point for you. One of the reasons why infections that involve areas close to muscle plane, close to these muscles, is significant because it can get within the planes of the muscle. In other words, a Bartholin cyst, which is a small cyst that can lie just in the medial aspect of the vagina, is a cyst that can swell, inflame, and rupture. Bacteria from that cyst can then get between the muscle fascial layers, and the bacteria can basically grow out of control. It's not in circulation, it's actually in a hollow space between the muscle layers. And so infections that get, bacterial infections that get within the muscle plane, typically will invade the entire pelvic structures, because it's very difficult to treat these with antibiotic therapy, and most of the time would involve incision and drainage of the wound, aggressive irrigation of the infectious organism. Same holds true in the male anatomy. Pilonidal cysts or pilonidal abscesses are abscesses that occur along the medial aspects of the buttocks, just at the point of the external anal sphincter. Many times these abscesses will enlarge, sometimes will rupture. If they don't rupture, many times physicians, surgeons will make incisions and open up these abscesses, because if they don't, if they migrate and they get between the tissue planes of the muscles, they can cause very severe infections, which would require significant debridement, again, larger incisions being made in irrigation. So these muscle planes lie on top of each other. The fascial layers, which have serous fluid that allow the muscles to move on top of each other, decreases friction, but it also can harbor bacteria in the right circumstances. And if bacterial infections get between the fascial planes, it will cause significant infections. These are, again, some of the superficial muscles of the back. I'll just quickly go over them. We'll go over them again when I show you the lab portion of the lab PowerPoint as well. The trapezius muscle, you'll have to identify, as you can see, its origin points beginning here along the vertebral column. Latissimus dorsi muscle, you'll have to be able to identify that muscle as well. Gluteus maximus, but I think I asked you to identify that on the pelvic portion. Remember these bony landmarks before: supraspinatus fossa, infraspinatus fossa. You should be able to identify the muscles that are there as well based upon the location. That would be the infraspinatus muscle. This would be the if I can get my arrow to work again, the supraspinatus muscle. Should be able to identify those muscles. Splenius capitis muscle, we talked about earlier, and the semispinalis muscle are involved in extension, posterior extension of the neck area, and also lateral rotation depending on which side you're on. If you're on the right side, you contract splenius capitis muscle. It pulls your head to the right. So as you study the muscles, look at them and imagine if the muscle shortens. Muscle shortens usually means it contracts, helps you to identify what the function is of that particular muscle. What else did I ask you before on here? I think that's pretty good. And I'll show you this again on another picture. But there are muscles that will attach here along the vertebral column, the rhomboids and the levator scapula muscle. But I'll show you that on a little better illustration. You can see the levator scapula muscle here. Levator scapula tells you what this does. It elevates the scapula bone. If it pulls the scapula up, look what happens. If it pulls the scapula up, it's going to drop the shoulder down. So as you look at that function of what that muscle will do. And then the serratus muscles, which also attach here as well. But I'll show you a little better illustration of that. And then the pectoralis major muscle and the pectoralis minor. Pectoralis minor isn't shown here. Pectoralis major muscle, you definitely have to identify. Deltoid muscle, you'd have to be able to identify that muscle. Very important muscle for injections as well. Gluteus maximus, one muscle. The pectoralis major muscle is the anterior chest wall muscle. Individuals who lift weights a lot like to develop the pectoralis muscles, and deep to the pectoralis major muscle is the pectoralis minor. Serratus muscles are muscles important in respiration. Don't remember if I asked you those muscles. I don't think I did. I don't think I asked you to identify that. The tendinous fiber sheet here, again, that's important. Now this is the rectus sheet, but basically this would be the area of the linea alba, and then as you can see, both on the right side and the left side, the rectus abdominis muscle lies. So the surgeon makes the incision either to the right or the left of the linea alba, which is this line here. Then he is making an incision through the rectus abdominis muscle. I think that was the question that was asked on the test. As we get to the lower extremity, some other, I'm sorry, I'll stay up top first. Biceps muscles should be able to identify. Posterior, behind the biceps muscle, on the posterior surface of the humerus, would be the triceps muscle. I know I have a picture coming up of that in just a bit. Sartorius muscle we'll talk about. The rectus femoris muscle we'll talk about. The vastus lateralis muscle we'll talk about when we get down to the lower extremities. And we're going to talk just a little bit about this site here, though I didn't ask you to identify this on the lab exam. It's referred to as the inguinal ring. Now, inguinal rings are important because there are basically two remnants in the abdominal wall that lead to deeper structures. One is the inguinal ring. Through the inguinal ring in males, the gubernaculum testicles will pass through. When we do the reproductive system next week, the gubernaculum testicles will pass through the inguinal ring, and then the ring will close. And so it's a remnant of an opening that leads into the abdominal cavity. The other area that's a remnant is the umbilical cord. The umbilical cord is a remnant of an opening that leads into an abdominal wall. The umbilical cord obviously is where the fetus will receive blood supply from the mother in development. And so two remnants are there, and these are two prominent areas where you can see a process referred to as herniation occurs. Intra-abdominal pressure increases, and if you get an increase in intra-abdominal pressure, the internal structures will attempt to take the path of least resistance, which would be the remnant, the opening for the gubernaculum testicle. So the inguinal rings would be one area. Another area would be through the umbilical cord. Now, we see some umbilical hernias. Typically, we see those in developing children. Children early in infancy may have an umbilical hernia, but as the muscles develop, as the linea alba develops and as the rectus abdominal muscles develop, you know, all little babies have this little pudgy stomach. You notice that when they're walking around, they got a pudgy stomach because the muscles haven't developed yet. Now, once the muscles develop, it pulls down, it contracts, and it increases the intra-abdominal pressure, and so the herniation usually will go away. In those cases, umbilical hernias in children, typically you don't treat them because as the abdominal muscles strengthen, the hernia will go away. Now, in some cases, in some children, they become very prominent and they don't go away, and those have to be surgically corrected. In an adult, inguinal hernias can develop. Hernia develops when organs protrude through an abnormal opening. Most common opening is the inguinal hernias and or diaphragmatic hernias. Now, where's the diaphragm located at? Big flat muscle that sits under the lungs, separates the thoracic cavity from the abdominal cavity. Now, it's a big muscle plane, but in the diaphragm, and when you look at your illustration, you'll see that the muscle layers kind of wrap around each other, and they allow the esophagus to pass through the diaphragm into the stomach. And so the stomach sits inferior to the diaphragm. The largest portion of the esophagus extends superior to the diaphragm. But what happens when increased intra-abdominal pressure pushes portions of the stomach through the diaphragm and it sits just above the diaphragm? Well, that's considered a diaphragmatic hernia. Inguinal hernias typically occur in males and typically occur at the inguinal canal that I was showing you earlier on the illustration. It's the site where blood vessels and nerves actually will pass through intra-abdominal organs, through the reproductive ducts, and through the abdominal wall as it reaches into the testicles. Elevated intra-abdominal pressure is usually the cause. It forces intra-abdominal structures through these small tissue openings. The diaphragmatic hernia develops, again, when the stomach is pushed up through the opening of the diaphragm. It forces contents of the stomach now to sit above the diaphragm. Remember, gastric acids in the stomach, very low pH, and so by design the stomach keeps those substances in the stomach. If you put a portion of the stomach above the diaphragm, then the gastric acids are now being produced above the level of the diaphragm, so the person usually has tremendous amount of reflux, will also aspirate on the acid that's in the stomach. If you aspirate on the acid in the stomach, remember acid is supposed to stay in the stomach, what happens is that individual will begin to develop a chemical pneumonitis in the lungs. They actually will begin to inhale the fumes from the hydrochloric acid in the stomach and begin to scar their lungs from it. So it can be in severe cases, it can be a very serious problem. If herniated structures become trapped or twisted, then surgery would be required. The blood vessels that lead from the intra-abdominal cavity through the inguinal canal into the testicles, if you pinch off those blood vessels are pinched off, tissue becomes ischemic, then it infarcts, then it dies, it turns gangrenous, and can lead to a very severe infection. And so surgical intervention is required. What happens is that inguinal ring, and I'll go back, that inguinal ring opens up, allows these organs to pass through, these structures to pass through and protrude, and then it'll pinch off again and close. And when it pinches off and closes, it cuts off the nerves in the blood vessels, so it can lead to major problems. Almost always will require surgical intervention to be able to correct it. Diaphragmatic hernia is the same thing can occur if the herniation is so pronounced you cannot control the production of gastric acid. Reflux symptoms are severe. Person also has develops a chemical pneumonitis from the recurrent reflux. Those individuals have to have surgical intervention as well. The advent of medicines like Prilosec, Prevacid, you've heard of Prilosec, Nexium, you've seen the commercials, I'm sure. These medicines have revolutionized the management of diaphragmatic hernias because those medicines can basically shut off the pump that generates the acid, and so the advent of those drugs have really reduced the numbers of gastric surgeries related to diaphragmatic hernias. So now the appendicular muscles. Appendicular muscles, these are musculars of positions. They stabilize the pectoral and the pelvic girdle and move the upper and lower limbs. There are two major groups of appendicular muscles, muscles of the shoulder and upper limbs, pelvic girdle and lower limbs. Functions are required range of motion, very different from one group to another. In addition of increasing mobility of the arms, the muscle connections between the pectoral girdle and the axial skeleton must act as shock absorbers. I talk about all the muscles basically together because there is certainly a significant relationship here between the axial and the appendicular muscles. They all work together in carrying out function. This is a great picture. A lot of structures here to be able to identify. Triceps brachii, muscles that connect and involve primarily extension of the arm, but as you can also see, they also will manipulate the positioning of the scapula as well. The levator scapular muscle, which I alluded to earlier, another muscle you'll have to be able to identify. And then the rhomboid muscles, just a group. It's a minor, smaller muscle, rhomboid minor, major, rhomboid major. I think on the lab exam I just asked you to identify these muscles, which rhomboid muscle would be acceptable. Trapezius muscle, big triangular muscle we see in the superior portion of the back. Points of origin would be along the vertebral column here, and it inserts, as you can see, at the shoulder area at the scapular spine. The muscles of the scapula I already asked you to be familiar with. Infraspinatus muscle, and then if we could see under the trapezius muscle here, we would see the supraspinatus muscle, and again the deltoid muscle, muscles that you'll have to identify. I don't think I asked you to identify the serratus muscle. Again, important accessory muscles of respiration, but I don't think I asked you to identify that on the lab. So muscles of the shoulder and the upper limbs, these muscles are associated with shoulder. Upper limbs can be divided into four groups: muscles that position the pectoral girdle, muscles that move the arms, muscles that move the forearms, hand, and muscles that move the hand and the fingers. Muscles that position the pectoral girdle, large superficial trapezius muscles that cover the back portion of the neck. These muscles originate along the midline of the neck and the back and insert on the clavicle and the scapular spine. The muscles that position the pectoral girdle also include the anterior muscles. We've already talked about the pectoralis major muscle. As you can see, deep to that, well, still don't have the pectoralis minor, sorry. Deep to that would be the pectoralis minor muscle. The deltoid muscle we already talked about. Deep to the pectoralis minor muscle, and I'm saying that right, pectoralis major, pectoralis minor, but even going more deeper, we see on the anterior surface, this is an anterior view of the body, so on the anterior surface of the scapula is the subscapular fossa. Remember that from the skeletal system. On that is a muscle referred to as the subscapularis muscle. I think I asked you to identify that. Can't be for sure, but I would know that one. This is another view now. We're looking at the posterior aspect of the body. On the posterior view, you can appreciate the latissimus dorsi muscle, its origin again along the vertebral column, and extension and insertion at the point of the humerus. And then you can also see, better view now, the supraspinatus and the infraspinatus muscles. Triceps brachii muscles also important. The teres major and minor muscles, when we look at the lab presentation, you'll see how these muscles are important and make the sits muscles, the muscles that are involved with the rotator cuff. And we'll talk about those a little bit more later, which sits supraspinatus, infraspinatus, teres muscle, make up those muscles. And we'll show those in just a little bit. Rhomboid and levator scapulae muscles, which I showed you back on an earlier illustration. These muscles, removing the trapezius muscle, have to take that away to be able to identify these muscles because they lie deep. The rhomboids and the levator scapulae muscles are attached to the dorsal surface of the cervical and thoracic vertebrae, insert along the vertebral border of each scapula between the superior and inferior angles. Contraction of the rhomboid muscles, adducts, the scapula on the side. The levator scapular muscle, as the name implies, elevates the scapula. And again, look at the illustrations at those muscles easily. Think about the muscle shortening. If the muscle shortens, what's going to be the response of the bone? Remember, typically, because it's a lever action, you'll see a response. Now, when we look at the vertebral column and we look at the scapula, obviously the muscle, the mass of bone is with the vertebral column, and so if the muscle shortens, most of the effect is going to be felt on the scapula. It's a freer, movable muscle versus the spinal column, but to a degree, you'll also get some lateral flexion from the vertebral column as well if that muscle contracts, so just take that into consideration. The serratus anterior muscles, basically on the anterior surface of several ribs. Fan-shaped muscle that inserts along the anterior margin of the vertebral border of the scapula. Serratus anterior muscle contracts. It abducts, abducts, protracts the scapula, and it swings the shoulder anteriorly. Some of the muscles that move the arm, the triceps muscle, as we talked about, especially with the extension of the arm. Triceps muscle lies posterior. As you can see, 2 points of insertion. One head will insert on the humerus muscle, the other is going to insert on the scapula, and then you also see, and when you see an illustration like this, I'm trying to remember, I probably asked you, I know I asked you to identify the triceps muscle. I'm not sure if I asked you to identify pronators, extensors of the wrist. But one thing that you always want to do on a photograph is identify what position are we looking at. Is this an anterior view or is this a posterior view? One of the easily identifiable muscles are the triceps muscles because they have 2 heads. And so you also can look and see deep here, you can see the electronon process of the ulna, and then deep to that you can see the electronon fossa, which would be on the humerus bone. So understand, when you look at a picture, identify whether you're looking at an anterior surface and a posterior surface. That will also help you to discern particular muscles. Now, as you can see, when we talk about muscles that move the arm, on the posterior surface of the arm, anatomical position, palms are facing out. Posteriorly, the muscles that extend the arms will lie posteriorly. Those which flex the arm will be anterior. So flexors are anterior, extensors are typically posterior. Remember, anatomical position. This is an illustration out of your book, again, demonstrating the deep layers of the muscle as you get down to the bone. Another point that I always like to bring out is also look at the relationship between the artery, vein, and the nerves. Again, we'll do the nervous system and the circulatory system next semester for those of you who take AMP2, but just recognize the bundle of these nerves that are together and the muscles which lie here in grouping, starting at the most superficial and going deep. These are the flexor muscles, so again, we must be looking at the anterior surface of the arm, flexor muscles, which will include the biceps muscle, points of origin and insertion, and then other muscles that are important that involve pronation and supination. Think of supination as you're drinking soup out of your hand, pronation away from supination, but muscles involved in pronation, supination, and also flexion of the arm lie anterior. You can see the brachialis muscle, brachioradialis muscle, flexor digitorum, superficialis muscle, flexor. All of these are flexor muscles. The palmaris, longest muscle. Palms are anterior, so it must be a flexor muscle. Palmaris, longest muscle. So in your mind, think of these groupings of muscles together. Flexors are going to be anterior. Extensors are going to be posterior. The flexor and extensor retinaculum we'll talk about. I couldn't remember if we've talked about carpal tunnel syndrome already or not. Muscles that move the forearm. Again, brachioradialis muscle. Already talked about flexors here anteriorly. Flexor, pollicis longus. Pollicis, the term that refers to the thumb, first digit of the finger. Pollicis longus typically means it extends to the most distal phalanx here of the finger, across the margin of the carpal bones, all the way to the most distal portion, if I can get my arrow to work, to the distal portion of the digit. There's also flexor digitorum profundus, which is a large muscle, again, reaches to the distal portion. These are the muscles that cause the flexion of the fingertips from these longest muscles. Also, a degree of flexion at the wrist, at the level of the wrist as well, involves the movement of these muscles. And again, you can see the insertion point of the biceps tendon, which is, again, runs primarily across the largest portion of the bellies of that muscle, run across the anterior portion of the humerus, thus involves the flexion at the elbow joint as well. So these are major groups of flexor muscles. The posterior view, again, we're talking about extensor muscles. The extensor digitorum muscle involves significant movement of the fingers, involves the extension of the fingers. Again, looking anteriorly, the name should tell you, extensor digitorum muscle, extensor in the digits, extensor digitorum muscle in its primary function. Abductors, abductors away from, abductors of the thumb, abductor, pollicis longus, abducts away from the body. And then supinator muscle, the name implies what it does, supinates the muscles of the arm. Supinator muscle are the major muscle groups. I don't think I asked you to identify many of the muscles or any of the muscles on the forearm. I don't remember any of those on the lab portion. Doesn't mean they're not important muscles. Just I don't think I asked you to identify any of those. And then the smaller, more defined muscles of the hand, interosseous muscles, which lie between the fingertips themselves. And then there are many smaller flexor muscles. And just as I talked about the muscle planes in the pelvic cavity, in the male and female, in the hands, there are a series of fascial layers that separate the muscles. We have so many fine movements of our hands. Similarly, in the feet, the anatomical structures, though just a bit different, are essentially the same. So many fine movements that are required by the muscles. The lumbrical muscles, as you can see, help us to be able to laterally move our fingers. The flexor muscles, digitae minimi brevis, adductor muscles, all these lie over each other to give us a number of movements of the hand. But again, if an infection gets into this fascial layer, if you get a puncture wound in your hand and an infection gets between the fascial planes of the muscles, it can cause severe problems. Individuals that suffer from infections in the hand, we send them immediately to an orthopedic surgeon or a plastic surgeon that specializes in hand procedures, because infections that get within the fascial planes of the muscles can lead to significant problems. But these are the muscles, the fine muscles that carry out fine motor movement of the hand. Dorsal aspect, again, these will be, as you can see, either adductors or abductor muscles. But again, if we're looking at the posterior surface, we recognize that these muscles, when they contract or pull, will cause extension of the digits themselves. The interosseous muscles are the little fine muscles, again, that lie between the metacarpal bones here of the hand. Now, there is a fascial tendon layer, again, that crosses the wrist. This is referred to as the extensor retinaculum. The fascia of the forearm thickens in the posterior surface of the wrist, forming an extensor retinaculum, which is basically a wide band of connective tissue. Extensor retinaculum holds the tendons and the extensors, the muscles, in place. Again, the extensors on the back. The anterior surface, there's also a flexor retinaculum as well. The fascia also thickens along the area and stabilizes the tendons, thus, of the flexor muscles as well. So you have an extensor retinaculum, you have a flexor retinaculum. Now, inflammation can occur in these retinaculums. It can significantly cause swelling, compression on the nerves that underlie this fascial tendon, and it can lead to problems of both mixed sensory and motor movement of the hand. The condition is referred to as carpal tunnel syndrome, and it's a form of chronic pain. Carpal tunnel syndrome, continual fine movement of the fingers, such as typing or working in a factory setting, leading to a form of inflammation referred to as tenosynovitis, which is basically inflammation. Carpal tunnel syndrome sometimes is referred to as tenosynovitis. Common condition that strikes persons as they're engaged in repetitive movement. Factory workers work at plants where you work with products, or typing, significant amount of typing, where you're using both flexor and extensor muscles, and so inflammation can occur. The problem is it's not much space in that joint. Once inflammation occurs under those tendinous sheets, the inflammation causes compression on the muscles and the nerves and the blood vessels that lie there, and the person will typically develop a significant pain syndrome related to that. So symptoms and pain include movement of flexion and extension, and there are specific tests that you can do in a clinical setting to elicit pain related to carpal tunnel. Carpal tunnel syndrome is an example of cumulative trauma disorder or an overuse syndrome. Again, repetitive movement. It's a significant cause of work-related disabilities. Two other deep muscles that arise on the ventral surface of the ribs, the subclavius muscle. I didn't ask you about that on the exam. And these are just tables out of your book that demonstrate muscles that move the arms. And please review those. I've gone over the major ones that you're responsible for. You should be able to identify the muscles of the rotator cuff. These are the sits muscles, supraspinatus, infraspinatus, teres minor muscle, and then the subscapularis muscle. So supraspinatus, infraspinatus, teres minor, subscapularis muscle, all are involved muscles of the rotator cuff. Again, another table here that demonstrates muscles that move the forearm, the flexor muscles, biceps, brachioradialis, and brachialis muscle. Then the extensor muscles, which will lie on the posterior surface of the arm and forearm, the aconius muscle, triceps brachii muscle, and triceps has two heads, a long head and a short head, but I didn't ask you to identify the heads. And then these are pronators and supinators of the arm, which are pronator muscles, teres and quadratus muscles, and supinator muscle. And then the flexor muscles of the hand, and there are a list of them. Flexor carpi radialis, flexor carpi ulnaris, palmaris longus muscle. Again, palmaris longus, think palm, anterior portion of the hand, must be a flexor muscle. And then the extensor muscles, as by their name, extensor carpi radialis brevis, and extensor carpi ulnaris, muscles of extensors. And then there are intrinsic muscles of the hand, the little fine muscles of the hand that I referred to earlier. They either adduct toward the midline, adduct the hand, or they abduct away from abduct the hand. And abductor pollicis, palmaris brevis, abductor digiti muscle, abductor pollicis brevis, flexor pollicis brevis, all are little small muscles, again, that control the finer movements of the hand. So muscles of the pelvic floor and lower limbs, we've alluded to some of those already, but the pelvic girdle tightly bound by axial skeletal, which prevents relative movement. The muscles that position the lower limbs are divided into three functional groups: the muscles that move the thigh, the muscles that move the legs, and muscles that move the foot and the toes. These are some of the groups of muscles. Again, I'll show you these again. We show the lab portion. Basically, these are the larger groups of muscles that will either abduct or adduct at the hip joint itself. Big muscles that you'll have to be able to identify: the gluteus maximus muscle. Again, this is a point at which you give a lot of injections. When you do the clinical part aspects of nursing, you'll see you use the iliac crest, which you had to identify last week, or week before, iliac crest, and helps you to be able to identify the location where you'd give an injection in the gluteus maximus. The vastus lateralis muscle. Vastus lateralis muscle is an important muscle not only in the movement of the leg, but it's also another site of injection, especially for children. I think that's a test question. Vastus lateralis muscle is one of the largest developing muscles in the child. If you look at a baby, the leg, the anterior portion of the leg and the lateral aspect of the leg, that muscle is pretty well defined. There are no major nerves, no major blood vessels that lie under this muscle. There's also a little margin for error because you have a vastus lateralis and a vastus medialis, and so you can give an injection in a child and not have to worry about hitting a blood vessel or a nerve. Now, the gluteus maximus muscle hasn't developed that well in the child yet, because in the infant, because they're not walking yet. Once they begin to walk, they'll develop the gluteus maximus muscle. But so early on in childhood, that's the best muscle to give an injection in. The other muscles here that are responsible for movement, and again, if you look at the position of the gluteus maximus muscle, for example, posteriorly, if this muscle shortens, what happens? It rotates the hip out, so you get an abduction of the hip. You also get a little bit of extension of the lumbar and sacral spine. And so think about these muscles when they shorten, helps you to identify what the action is. The gluteus minimus muscle, for example, if it contracts, if it shortens, you'll see abduction again of the hip. Some other muscles here that you'll have to identify on the lab portion: iliopsoas muscles, large groupings of muscles here. Again, as you can see, these muscles contract or shorten. You're going to draw the hip in. The adductor muscles, the adductor magnus muscles, you'll have to identify in the lab. Again, these muscles contract and shorten. They adduct the hip joint itself. The muscles such as the sartorius muscle, which helps to cross your legs when it shortens. So not only does it adduct the hip, but it also will help assist a person in crossing their legs as well. Trying to remember what other muscles I asked you to identify with this one. Adductor magnus, the iliopsoas muscles, sartorius muscle. Another illustration here. This is the posterior aspect of the leg. Why do we know it's the posterior aspect? Well, we see the gluteus maximus muscle is the number one landmark, but you also can appreciate the iliac crest as well. Gluteus maximus you have to identify. Should be able to identify this. And now this causes posterior flexion of the leg. You look at the biceps femoris muscle. You should be able to identify. Semitendinosus muscle, these are muscles of the hamstring. You should be able to identify those two major muscles as well on the posterior aspect of the leg. And here are the muscle groupings: muscles that move the thigh, gluteus maximus muscle, medius muscle, minimus muscle, the tensile latae muscle, I didn't ask you about that. Lateral rotators, the obturator muscles, the piriformis muscle, didn't ask you about that muscle, the quadratus femoris muscle on the lateral border. And then the abductor, adductors of the hip group, adductor brevis longus and magnus, pectineus muscle and gracilis muscles. And then the major groups of muscles, again, that I alluded to earlier, adductors, the iliopsoas groups, the iliacus and the psoas major. But again, I asked you to just be able to identify it as the iliopsoas muscles. Muscles that move the thigh, as we look anteriorly, I already talked about the vastus lateralis. Definitely have to be able to identify that muscle. The rectus femoris muscle, which is the most anterior lying muscle. As you can see, the points of insertion here at the patella on the distal aspect of the femur. We already talked about the iliopsoas, and we looked at that at a different angle. And these were the gracilis muscles, the torus muscles that I showed you earlier. Again, adductors, but you also can see where it will allow the individual, if the muscle shortens, it also allows you to cross your legs. In this view as well, you can identify the vastus lateralis, again, an important muscle for an injection for an infant. As you can see, between the integumentary system and the bone, there are no major blood vessels or nerves here. This is why it's a very good muscle to be able to use in infants. Also, if the angle of the injection goes one way or the other instead of going perpendicular to the axis here, then you can see there's also a repetitive group of muscle tissues that lie deep to it. And so it's no risk of injury, and that's why the vastus lateralis is a great site to be able to give injections in children. If we went more medial, as you can see, there are a number of blood vessels and nerves that course medially in an infant. So groups of muscles that flex the knee: biceps, semitendinosus, sartorius muscle, popliteus muscles. Extensors of the knee are muscles such as the vastus medialis, vastus lateralis, and the rectus femoris muscle. And down at the very lower aspect of the extremity, also muscles you should be able to identify. And these muscles, again, you got two functions down at the lower extremity. Think about the foot. You have plantar flexion. Plantar flexion, the foot is being pushed down toward the ground, planting seeds, plantar flexion. And then you have dorsiflexion, where you're actually angling your foot back toward the anterior surface of the leg. So you have plantar flexion and you have dorsiflexion. Plantar flexion and dorsiflexion. And the groupings of muscles as function is described is based upon whether it causes plantar flexion or dorsiflexion. Gastrocnemius muscle, you'll have to be able to identify. Gastrocnemius muscle, and also soleus muscle, which lies deep to the gastrocnemius muscle. The gastrocnemius muscle is an important plantar flexor of the foot. Again, if that muscle contracts, the foot goes down toward the ground, so plantar flexor. Also connected here to the calcaneus bone by a huge tendon, the calcaneal tendon, also referred to as the Achilles tendon. The other muscle that's important in this group is the soleus muscle, similar function. These two muscles work in coordination. Soleus muscle is a common spot. This is not on the test, but it's a common spot for biopsies, for muscle biopsies. If a person has a muscular problem, this is a common site where biopsies are taken from. So again, gastrocnemius muscle, soleus muscles, two muscles that you should be able to identify on the foot. The gastrocnemius muscle, again, plantar flexors. Your book also labels it as an extensor of the foot. Remember, you're on a posterior surface anatomical position would also be considered an extensor as well. But plantar flexor is the term that you should be able to appreciate. And then the dorsiflexors, it's only one dorsiflexor. You need to know it. I think definitely a test question about that. Tibialis anterior. So it opposes the motion of the gastrocnemius muscle. Anterior flexor, so it's going to cause dorsiflexion of the foot, or the foot to move back up toward the anterior surface of the tibia. Tibialis anterior, dorsiflexor, gastrocnemius, soleus muscle are the two primary. Plantar flexors or extensors when we look at the lower portion of the leg. And here's an illustration that demonstrates plantar flexion. As you can see, contraction here would occur. Now the gastrocnemius has been moved off this picture, but as you can see with plantar flexion, this would be caused by contraction of the gastrocnemius and the soleus muscle, which would be lying here. It has been removed, and you see some deeper muscle structures. Again, similarly to the names, instead of pollicis, we see inserted holocaust, which is basically the large toe or the great toe, but we see the names. But still, flexors and extensors, longus and brevis, which account for lots of the fine movements that we see in the toes. And we don't manipulate our toes as well as if you believe our ancestors are the apes, but there's still, you can see we have a lot of the fine movements that we have in our hands. We can see those same movements in the toes as well. Lateral views of the gastrocnemius muscle, a lateral view of the tibialis anterior muscle. Must be a lecture question because I don't remember actually asking you to identify that on the lab, but again, you can see the course of the tibialis anterior muscle and why that would be an opposer of the gastrocnemius and the soleus muscle. Again, when this muscle shortens, the toes are going to come up, the foot's going to come up, causing dorsiflexion of the foot. Again, actions of the toes, some of the smaller muscles of the toes. Not that they're not important, but I didn't ask you any questions about these. The flexor digitorum muscles, both longus and then flexor digital extensor muscles, extensor digitorum longus, which would cause or be involved more in plantar flexion of the foot. And then the retinaculum, as we talked about on the wrist, you can see these retinaculums already extensively running across, forming a Z across the anterior surface of the foot. Now, you don't get many instances of the syndrome, the tenosynovitis that we see in the wrist, in the foot area, though you can get a condition referred to as plantar tendinitis, which is basically inflammation of this tendon that courses along the sole of the foot, again along the plantar surface. The flexor digitorum brevis muscle is involved in that pain process because many people, normally anatomically, there is a little spur that comes off the calcaneus bone. That's normal. And in most cases, it does not cause inflammation. But if you take an x-ray of a calcaneus bone, you see that little spur, and if the person is complaining of pain, it's quickly referred to as, oh, well, he must have a bone spur. Actually, it's the inflammation of the tendon of the flexor digitorum brevis, that's a muscle you'll have to identify for the lab, or the inflammation in the plantar aponeurosis, or the plantar tendon, is actually what's causing the pain. Once inflammation occurs in this area, the only thing, I won't say the only thing, the best way to alleviate the pain is to stop the movement of the foot. So if the person works by walking all the time, if the person is standing all the time, then it's almost impossible to resolve this inflammation because it involves continually moving the foot. If you're continually using an inflamed joint, then it won't heal. So the best treatment for this is to put them in an immobilizing splint, sometimes weeks to days. You can give injections. I give injections all the time right into that tendon. Hurts like a son of a gun, but it really, a cortisone injection right on that tendon knocks out the inflammation. And the person will get improvement for a period of time. But if they're still walking on it, after the cortisone wears off, the inflammation will come back. So the best way to resolve that problem is to stop the flexion, the plantar flexion and the dorsiflexion of the foot. So you have to immobilize the foot. I think that's the only muscle I asked you to identify on the foot down there. Now, one other aspect that I'll mention here just quickly, those of you who do the disaster course this weekend, the is a concept referred to as compartment syndrome. Compartment syndrome is something we see in crushing injuries. So a large heavy object falls on an extremity. May not break the bone, but it damages the tissue. Blood is released, if I get my arrow to work again, blood is released from the blood vessels here in this crushing injury. And what happens, because there are these fascial layers, these compartments that are made here, bleeding occurs inside this compartment and it swells up the compartment. As you can see, there's not a lot of room for things to move here. So when swelling occurs, compression will occur on adjacent tissues. These other blood vessels will become constricted from the swelling. The swelling literally cuts off the circulation. So a crushing injury to my arm, blood vessels rupture inside, swelling occurs. Swelling occurs here to such a degree that the skin becomes taut, and it literally cuts off the circulation to the remainder of the extremity. referred to as compartment syndrome. Now, the problem with that is if I lose circulation to the distal portion of my hand, I lose this whole hand and this whole portion of the arm. So in compartment syndrome, the immediate treatment for this are what's referred to as fasciotomies. You basically have to make incisions along these compartments to allow the tissue to expand. This will reopen the blood vessels and allow circulation to get to distal portions of your extremity. The other downside to compartment syndrome, the crushing injury if something is laying over the extremity and this extremity has had a chance, its circulation has been cut off. Remember, lactic acid production in our system. We got to go way back to the first part of the semester when we talked about metabolism. But lactic acid is generated. Lactic acid is very acidic. And so you remove the heavy object, you do the fasciotomies, you release the pressure, blood flow returns, all the acid that accumulated, all the damaged cells that accumulated in this hand now go into the circulation. And in many of these instances, when you alleviate the compartment syndrome, you now put all those toxic cells and all that lactic acid into the system, and it can lead to electrolyte imbalances, it can lead to kidney failure because all those damaged cells get filtered out through the kidneys and plug up the kidneys and work. So compartment syndrome can lead to significant problems. And you can read like a little